All right, let's dive deep into two trials that really flip the script on how we think about blood transfusions in critical care. TRICC and TRISS.
You got it. And before we even get to these studies, it's wild to think that just a few decades ago, most folks thought giving tons of blood to super sick patients was like the obvious move, you
Yeah,
know?
like more is always better.
Exactly.
So before we get lost in the
Yeah.
details, could you set the stage a bit? What's the deal with transfusions in critical care anyway? Why are they so important?
Well, think about it. Someone comes in, massive blood loss, maybe from an accident, surgery, or even a really nasty illness.
Right.
A transfusion that's taking blood from a donor and giving it directly to that patient can be a total lifesaver.
Replaces what's missing.
Replaces that lost blood, yeah.
Hmm.
Gets oxygen flowing to the vital organs, helps with clotting, the whole 9 yards.
Makes sense. But like anything medical, I'm guessing there's a flip side.
Oh, yeah, for sure. Transfusions, they can be amazing, life-saving even, but there's always that risk.
Complications.
Yeah. Sometimes it's mild chills, fever, that kind of thing.
Right.
But then you got the more serious stuff like allergic reactions, lung issues, even a chance of infection from the donated blood itself. So it's a balancing act.
Weighing those benefits against the risks. And that brings us right to TRICC, right? This trial, back in 1999, it really challenged that whole more is better thinking. That was pretty common back then, especially when it came to transfusions.
Big time.
What was the medical world like before TRICC came along?
Well, it was almost like this dogma, more is better. Doctors, they were all about keeping hemoglobin levels, that's the measure of oxygen-carrying red blood cells, they wanted it high in critically ill patients.
I see.
Like 10 to 12 GDL, that was the target. More hemoglobin, more oxygen, faster recovery. Seemed logical at the time.
Fill up the tank.
Exactly. Except nobody had really tested that rigorously. And as we talked about, those transfusions, they come with risks. So that's where TRICC comes in, asking this really big question.
Yeah, what's the actual deal with this more is better approach?
Yeah. Right. Is it truly the best way?
So break it down for us. What was the TRICC trial all about? What were the researchers trying to figure out?
So TRICC, that stands for Transfusion Requirements in Critical Care. This study, it was huge. Over 800 critically ill patients, all anemic, in ICUs across Canada.
Right.
They were randomly assigned to get transfusions, but with two different strategies. You had your restrictive strategy.
Okay.
Doctors only gave blood if the patient's hemoglobin dropped below 7 GDL.
Interesting. And then what was the other one?
The liberal strategy, that was all about maintaining that higher hemoglobin level, at least 10 GDL, which, as we said, was pretty much standard practice at the time.
Head-to-head comparison.
You got it.
What did they find?
Well, this is where it gets really interesting. They found that the restrictive strategy, the one where transfusions happen less often, was actually linked to better survival rates.
Really?
Yeah. Patients in that group, lower risk of dying within 30 days compared to the folks getting more frequent transfusions.
That is surprising.
It shook things up, for sure. It challenged that whole belief that more blood equals better outcomes. But, of course, you had some folks pushing back.
Sure.
Concerns that 7 GDL for hemoglobin was just too low could be dangerous. And others wondered if these results would apply to everyone who is critically ill, not just the specific people in the TRICC study.
Valid questions.
Absolutely. But you gotta weigh those concerns against what the evidence showed, right?
Yeah.
TRICC, it was a big, well-designed study. Couldn't just ignore those findings. It gave strong support to the idea that this restrictive approach was at least as safe, if not better, than the liberal one.
So TRICC focused on critically ill patients as a whole. What about sepsis? I mean, that's a serious condition where transfusions are often needed.
Yeah. Sepsis, that's where TRISS comes in.
Sorry.
Stands for Transfusion Requirements and Septic Shock. This one came out in 2014, about 15 years after TRICC.
Much later.
Similar design, though. Almost 1,000 patients with septic shock, ICUs across Scandinavia. Again, randomly assigned to either restrictive or liberal transfusion strategies.
So did TRISS use the same hemoglobin targets as TRICC?
Pretty close, yeah. The restrictive group, transfusions only if hemoglobin went below 7 GDL. The liberal group, they aimed a little higher, 9 GDL. But that core idea comparing restrictive versus liberal, that stayed the same.
Gotcha. Slightly different targets, but the same setup. So did they find the same thing as TRICC?
They did. Trust no difference in mortality between the groups. More support for that restrictive approach.
Another win for the restrictive strategy.
And get this, TRISS found something else pretty remarkable. The restrictive group, they needed half the units of blood compared to the liberal groups.
Wow.
Huge difference, right? Especially when you think about blood shortages, it's a big deal.
Yeah, absolutely.
Hmm.
We've talked a lot about these trials and how they shifted the thinking about blood transfusions, but no study is perfect, right?
Oh, right.
What were some of the weaknesses or limitations of TRICC and TRISS?
Well, with TRISS, one criticism was that it ended early. Not enough patients enrolled, so it might not have been able to spot small differences between the strategies.
I see. So maybe there are subtle things it missed.
Could be. And got to remember, both these trials, they happened before some of the newer blood products were widely used.
Oh, okay.
Leukoreduced blood, that's blood with the white cells removed, lowers the risk of some complications. Pretty common practice now, so TRICC and TRISS. They might not apply directly to situations where those newer products are being used.
Right. Things have changed.
Yep. And another thing, TRICC wasn't blinded. Doctors and patients knew which strategy they were getting.
Uh-huh.
Results were still significant, but that lack of blinding could have introduced some bias,
That makes sense.
So it's crucial to see these trials within their time. Medical knowledge, it's always evolving. Our understanding of critical care and sepsis, it's come a long way since those trials. So ongoing research, that's absolutely key.
Absolutely. Make sure our practices are up to date.
Exactly.
Okay, so I think it's time to switch gears a bit and talk about what these findings really mean.
It's interesting, these trials, they kind of fit into this bigger trend in medicine, moving away from those super aggressive treatments unless there's solid evidence backing them up.
Makes you wonder, right? What's the secret sauce behind this restrictive strategy? Why does it seem to work just as well or even better than giving more blood?
Well, there are a few ideas floating around. One is that, well, the human body is incredibly adaptable,
For sure.
It can adjust to low hemoglobin in a bunch of ways. It's almost like think of a super athlete pushing their limits. The body can ramp up that cardiac output. That means the heart pumps more blood with each beat to make up for having fewer red blood cells.
I see.
It can also get smart about blood flow, sending more oxygen to those key organs, the brain, the heart, and less to places that can handle it, like the skin or limbs.
Wow.
And the body can even kickstart production of brand new red blood cells to replace the missing ones. So even with a slightly lower hemoglobin level, it doesn't always mean the body's starving for oxygen.
That's amazing. We underestimate our bodies sometimes.
We really do. And then there's the second idea. It goes back to those transfusion risks we talked about. The restrictive strategy, well, it just means fewer of those risks.
Yeah.
Fewer transfusions, lower chance of infection, lung problems, allergic reactions, all that.
Yeah.
And this is super important for those critically ill patients. They're already vulnerable, maybe with weakened immune systems.
Sometimes instead of rushing to fix things,
Yeah.
we need to let the body do its thing.
Exactly. Less is more sometimes.
So far, we've been talking about survival, that being the main focus of these trials. But I'm curious, what about the bigger picture? When we think about blood transfusions, what other things should we consider, especially for each individual patient?
Right. Survival is obviously crucial, but it's not the whole story, right? You gotta think about quality of life, too.
Of course.
Like, will giving more blood really help them bounce back faster, shorten their hospital stay? Will it actually make them feel better during recovery? These are big questions.
Yeah. And could a more restrictive strategy, even if it's not riskier in terms of survival, could it still impact quality of life negatively?
Exactly. These are all those tough conversations that doctors, patients, families, they need to have together to figure out the best approach.
Right. It reminds me of that idea of personalized medicine, tailoring treatment to each person's specific needs and situation.
Absolutely. We're moving away from those one-size-fits-all guidelines, getting more personalized. Maybe one day we'll even use those biomarkers, or genetic info to figure out who benefits most from which strategy, restrictive or liberal. Imagine treatments as unique as the people getting them.
That's pretty incredible.
Hmm.
Also wondering about the long-term effects of these different strategies. Do we know anything about how they might impact recovery time, rehab, or the chances of developing chronic conditions down the line?
We definitely need more research into those long-term outcomes. But some studies suggest that folks who get fewer transfusions, they might actually recover faster and have fewer complications after they leave the hospital. Fewer complications early on could translate to a smoother, faster recovery overall.
Makes sense. And fewer transfusions, that means less strain on the healthcare system, especially with blood being such a precious
Oh,
resource.
for sure. Those economic impacts are huge. Fewer transfusions, lower healthcare costs, both for individuals and for the system. It's like making sure those life-saving units of blood are available for those who absolutely need them.
It's all connected, isn't it? The patient, the healthcare system, even the global blood supply.
Absolutely. And as we go forward, it's all about exploring those connections, making sure our practices are backed by the best evidence and ethical thinking. TRICC and TRISS, they were big steps forward, but that journey of discovery, it continues.
And what a journey it is. We've gone from the history of transfusions to personalized medicine. It's been fascinating.
Mhm.
Before we wrap things up, what's the one big takeaway you want our listener to remember from all of this?
I think the big thing is, medical knowledge, it's always changing. What we think is the standard today could be totally different tomorrow, thanks to new research. It's all about asking those questions, staying in the loop, and having open chats with your doctors.
Like taking charge of your own health journey, right?
Yeah.
Ask those questions, do your own research, make sure you really get the whole picture, the risks and the benefits.
Absolutely. TRISS, CC, and TRISS, they were huge, but they also opened up all these new research paths, like one super exciting area that's blood substitutes, artificial blood.
Wow.
Imagine that. A safe, effective alternative to donor blood, ready to go whenever you need it. Game changer, especially in emergencies or places where blood banks are hard to come by.
It'd be like a universal blood type, always on hand.
Yeah.
Incredible.
Yeah. And these trials also got us thinking about resource allocation in healthcare. Using blood transfusions more carefully, it helps the individual patient, but it also impacts the whole system.
Right. Making sure those life-saving resources are available when they're really needed. It
Yeah.
makes you think about what a good outcome really means in healthcare.
Absolutely. Is it just about living longer, or is there more to it?
Quality of life, patient values, making decisions together with doctors and families. It goes beyond just the medical stuff.
It really does. At the end of the day, healthcare is about people, understanding their needs, respecting their values, and working together to make the best choices, even when things are uncertain.
Couldn't have said it better myself. A huge thank you to our amazing expert for walking us through these groundbreaking trials.
You're welcome.
And to you, our listeners, thanks for joining us on this deep dive. We hope you've learned something new, something that makes you think differently about healthcare and the power of research. Remember, knowledge is power, and it all starts with curiosity. Until next time, keep exploring. Keep those questions coming.